Book, but I thought that this may be my only chance to talk to you about some of the pharmaceuticals that you may be coming in contact with. Most of the pharmaceuticals, of course, are prescribed and they are dosed out by physicians, and so you don't have to worry about them. But there are some people that take more than they're supposed to, like the opiates, and then we have trouble. But these are all the medications that you wouldn't want to overdose with. You wouldn't want to take an extra shot of selective serotonin reuptake inhibitors. Probably, just to guess, because it wouldn't really do anything for you. Some of these are dangerous. And so you may come across somebody who's taking a tricyclic and wonder, wait a minute, tricyclics. Is there any problem with tricyclics or SSRIs? I've been reading about SSRIs lately. There's a lot more side effects to SSRIs than people realize. So let's go ahead and get started. And I think the first thing I'm going to talk about is selective serotonin reuptake inhibitors. There we go. The mechanism of action for SSRIs, antidepressants, they inhibit the serotonin reuptake, and so that increases the level of serotonin in the synaptic cleft because it can't take up the serotonin. It leaves it in the synapse, and of course it makes you feel better. Many SSRIs affect other receptors, especially at high doses. SSRIs clinical effect usually takes weeks, so the mechanism goes beyond simply increasing synaptic serotonin levels. There are several serotonin receptor subtypes. Serotonin receptors are located throughout the body, especially in the GI tract, so this is in your gut. All SSRIs except Luvox are FDA approved to treat depression, major depressive disorder, and dysthymia. Dysthymia, of course, isn't in the DSM-5. It's not in the DSM-5. It was in the DSM-4, DSM-4-TR, but now they've done away with that concept of low-level depression, continual low-level depression. Various class members of SSRIs are also approved to treat generalized anxiety disorder, OCD, panic disorder, PTSD, eating disorders, premenstrual dysphoric disorder, and social anxiety disorder. Off-label uses, they use it for ADHD in select cases, insomnia, chronic pain syndromes, seasonal affective disorder, behavioral problems in individuals with dementia and an intellectual disability. And of course, I've come in contact with that working in nursing homes. Working with nursing homes. I can't say I worked in a nursing home. Half-life, it's short. There are several different types of SSRIs. The short half-life SSRIs would be Paxil or Luvox. With Paxil and Luvox, of course, if you miss a dose, then all of a sudden, don't do it. You start getting nauseous. The moderate half-life SSRIs are Zoloft, Celexa, and Lexapro. And the ones that have, and this is one of the reasons why they like Prozac. If you miss a dose, you don't have to worry about Prozac because it stays in your system a little bit longer than the other SSRIs. But if you miss Zoloft, Celexa, or Lexapro, you got a problem, and it's the same way with Paxil and Luvox. Side effects: decreased sex drive and impaired sexual function tend not to resolve with time. Nausea, diarrhea, anorexia, vomiting all increase with doses and can be resolved with time. Weight gain, especially Paxil, paroxetine, after initial GI effects, then you gain weight. Usually the GI effects are nausea, diarrhea, and vomiting. Headache, dizziness, anxiety, especially Prozac, fluoxetine, Rash, insomnia, sedation, sweating, vivid dreams, tremor, dry mouth, especially with Paxil, bruising, increased prolactin, the protein that enables females to produce milk. Another side effect that they have discovered, they didn't really discover it. They knew it was there, but they weren't really talking about it because it was only in select individuals. It's called emotional blunting. Emotional blunting has to do with not feeling as strongly emotionally about people that you felt strongly emotionally about before. So what we're seeing is divorces from husbands and wives because whichever individual is taking the SSRI, whichever individual is taking the SSRI, they don't seem to like the person as much as they did before. We're also seeing children reacting negatively to parents taking SSRIs because they don't treat them the same as they did before. So it's called emotional blunting. Drug-to-drug interactions, Luvox increases Prozac, increases Paxil, increases Zoloft, increases Celexa, which increases Lexapro. So don't take any of your SSRIs together because you'll just get an accelerated reaction. The interacting effects may be dose dependent, especially with Zoloft. SSRIs levels tend not to be altered by other drugs, but they can potentially increase levels. They can inhibit your metabolism of certain drugs depending on what you're taking. Examples: Paxil increased risperidone. Of course, risperidone is an antipsychotic. Prozac increases buspirone, which is an anxiolytic. And Luvox increases olanzapine, which is also an antipsychotic. So you have to watch when you're mixing your antipsychotics with your SSRIs. Caution suicidal ideation and increased suicide risk, especially with children early in treatment, but there is a significant debate as to whether that is true or not. It has happened in the past, but there's a question as to whether it was the SSRIs or not. Serotonin syndrome is SSRIs plus monoamine oxidase inhibitors and possibly lithium, and there may be others, but we haven't discovered them yet. Serotonin syndrome is diarrhea, tremors, sweating, restlessness, hyperreflexia, leading to a progression of symptoms if untreated, and of course most people do report a negative problem if you've got diarrhea, tremor, sweating, restlessness, and hyperreflexia. You're going to tell your physician. Hopefully, you'll tell your physician. Can cause disorientation, rigidity, fever, which can lead to coma. These individuals sometimes will have seizures. And a lot of times the coma or the seizures will lead to death. And that's about 10% mortality rate on these individuals. Many medications, substances have serotonin activity. Dextromethorphan, which is a cough medicine, don't mix the two. Fentanyl, which is an opioid, don't mix SSRIs with fentanyl. Meperidine, which is an opioid commonly called Demerol, you can't really mix it with serotonin. Sumatriptan, which is a migraine headache medication, is not good. St. John's wort, which is an herbal antidepressant. If you're taking one, don't take the other. Anything that increases your serotonin level, like MDMA, which is the chemical configuration of ecstasy or LSD, they increase your serotonin level, and of course you wouldn't want to take an SSRI with something that is already increasing your serotonin level. Citalopram is the chemical name for Celexa. It has few drug-to-drug interactions. It has high serotonin specificity. It's typical or it has typical or less SSRI side effects. Lexapro is there's no generic available for it. It's very simple dosing. Fluoxetine, also known as Prozac, Seraphim, Symbyax with Zyprexa. It has a very long half-life. One of the things you need to remember. Takes a while to get into your system, takes a while to get it out. It has significant drug-to-drug interactions. So if you're taking Prozac, watch what other medications you're taking. Luvoxamine is another name, or fluvoxamine, I'm sorry, is another name for Luvox. It's usually used for OCD, obsessive compulsive disorder, multiple significant drug-to-drug interactions. So if you're taking Luvox, stay away from other medications. Paroxetine is another name for Paxil, significant drug-to-drug interaction. Some reports have associated weight gain, withdrawal symptoms with missed doses. Sertraline is another name for Zoloft. It has moderate drug-to-drug interactions, and it has multi-step dosing, which makes it kind of interesting to administer. The atypical antidepressants, there are new antidepressants that are not less serotonin specific or affect serotonin differently than SSRIs. In 1981, trazodone, also known as Desaril, was developed. 1989, Wellbutrin, bupropion was developed. Effexor was developed in 1993. Venlafaxine, 1993. 1994, Cerazone, nefazodone was developed. 1996, Remeron, mirtazapine is another name for that. 1996. 2004, Cerazone was discontinued through generic, although generics are still available, mostly in Europe, not in the United States. 2004, Cymbalta was developed. And it's not usually used alone. It's usually used with antipsychotics. Duloxetine is the name, another name for Cymbalta. Okay. Effexor and Cymbalta are both serotonin and norepinephrine reuptake inhibitors, SNRIs. Remeron has serotonin subtype and norepinephrine activity. Trazodone and nefazodone have different serotonin activity than SSRIs. They affect other serotonin receptor sites. Bupropion has dopamine and norepinephrine activity, so it is not the same. Doesn't work on serotonin. Indications of off-label uses: all typical and atypical antidepressants have FDA approval to treat depression. SNRIs have been shown to be effective in chronic neuropathic pain. Wellbutrin has been approved to treat nicotine addiction. Wellbutrin can augment SSRIs to reduce SSRI sexual side effects. Wellbutrin does not have sexual side effects. Remeron and trazodone are used to treat insomnia. Both atypical antidepressants have many similar uses to typical SSRIs, so we see trazodone. Trazodone is the one that they gave to people suffering from PTSD. Desaril, it was used because it allows the, especially combat veterans from Vietnam, because it allows them to skip over the delta wave sleep in the beginning. The problem with trazodone was that because it makes you jump over the first your first deep level sleep, you didn't feel as rested when you woke up, even if you slept for the same amount of time. So that was a problem. But they used it to lessen the effects of PTSD. Wellbutrin and Remeron, trazodone, and nefazodone do not usually have associated sexual dysfunction. Because they don't increase the serotonin level that much. The reason they have sexual side effects, as we know, is because it increases the serotonin in your hypothalamus, and your sex drive is testosterone in your hypothalamus. That creates your sex drive. So the more serotonin you're increasing, the more likely you will have a problem with your sex drive. And these four do not, they increase your norepinephrine level, but not so much your serotonin level. Effexor is similar to tricyclics with less safety and side effects concerns. Effexor has FDA approval for depression and generalized anxiety disorder and social anxiety disorder. As an SNRI, Effexor activity depends on dose. Effexor has a minimal drug-to-drug interaction. Effexor has side effects with missed doses that are fairly extreme. Well, nausea and vomiting. Duloxetine or Cymbalta is an SNRI that has minimal dose dependency. Cymbalta is indicated for depression and chronic neuropathic pain. Bupropion, Wellbutrin, and Zyban. And if you remember some of the old commercials about Zyban was used as for people that for nicotine cessation. Bupropion is a norepinephrine and dopamine reuptake inhibitor. Zyban is used to treat smoking addiction. Bupropion is a seizure risk in certain patients, especially at high doses. Bupropion's drug-to-drug interactions are not often significant unless you are taking monoamine oxidase inhibitors, which you shouldn't be taking any other antidepressant with monoamine oxidase. Mirtazapine or Remeron is a complex serotonin that has norepinephrine, alpha-2, and histamine activity. Mirtazapine has receptor activity changes with changes in dose. Mirtazapine has sedation and weight gain, especially at lower doses. Mirtazapine usage can have lipid abnormalities. Remeron has minimal drug-to-drug interactions, except, of course, with monoamine oxidase inhibitors. And one of the things we're going to notice with most of your antidepressants is there is a weight gain. There can be a weight problem if the individual doesn't exercise. Nifazodone or Cerazone. Nifazodone is rarely used due to irreversible liver toxicity, so you probably won't see it. It's used in Europe, but not so much in the United States. Nifazodone was pulled from the market by the initial manufacturer in 2004, although it is still available as a generic, especially in Europe, as I said before. Nifazodone is still popular with some patients, and it's questionable as to why some of these drugs work on one person, but they don't work on others. Trazodone or Desaril causes sedation, weight gain, low blood pressure. It is used most commonly off-label for insomnia. That's what I was saying with the people suffering from PTSD. Makes you skip over your delta wave sleep. So it puts you to sleep fairly quickly, but you jump over delta wave and you don't get as restful a sleep. There are rare reports of sustained painful erections, also known as priapism, that should be treated in the emergency room because it can stress the blood vessels in your penis and cause impotence. So there you go. Okay, so that's the SSRIs. Now we're going to talk about the tricyclic antidepressants. The tricyclic antidepressants describe a group of drugs with similar structure and function. The thing about the SSRIs, they were developed in the 70s and 80s. Before that, the antidepressants that they had were fairly toxic. tricyclics, and monoamine oxidase inhibitors. Tricyclic antidepressants describe a group of drugs with similar structure and function. They're abbreviated as tricyclic TCAs. They were developed in 1958. 1958, imipramine failed an investigation as an antipsychotic, but it was found to have antidepressant properties. So they developed the drug as an antipsychotic. Didn't work, but it did work on depression. So they started giving it to people in the 1960s. 1960s, multiple other tricyclics were developed. Imipramine, nortriptyline, doxepin, amitriptyline. These are all the tricyclics. 1990s, significant reduction in use due to introduction of SSRIs, which had fewer side effects. So the SSRIs were being developed in the 70s and 80s, and they hit the market real hard in the 1990s. For the longest time, Prozac was the leading, the most widely used drug in the world. And it was knocked off its pedestal by Viagra, interestingly, as interesting as that is. The mechanism of tricyclic antidepressant action, there is norepinephrine, serotonin, histamine, muscarinic and cholinergic, and alpha cholinergic receptor activity in differing ratios. Anticholinergic activity leads to many of the side effects of these drugs. It is used for depression and similar spectrum of disorders as is SSRIs. So that would be OCD, insomnia. Tricyclics are especially helpful with chronic pain and depression, secondary to medical conditions such as AIDS. So it is still out there and it's still being used. Side effects include enuresis, can't pee, I'm sorry, you can't control your urination, narcolepsy, premature ejaculation, insomnia, migraine, and prophylaxis. Blood may be obtained to monitor dose effectiveness, and that is the first time I came in contact with tricyclics, not as a psychologist, but as a laboratory technician, because we were drawing levels on individuals every month. So we came in contact with the tricyclics. Drug-to-drug interactions for the tricyclic antidepressants. Tricyclics have multiple significant interactions in each direction with potentially serious consequences. And this is one of the reasons why tricyclics aren't as popular as SSRIs. Most SSRIs do have some kind of some degree of interaction, but tricyclics tend to have a lot of interaction. Side effects of TCA and the side effects are fairly problematic. Dry mouth, constipation, blurred vision, and urinary retention. Cardiac arrhythmias and conduction changes in the heart. Orthostatic hypotension. Sedation, weight gain. Nobody likes weight gain, but we see that with the other antidepressants as well. Cautions when taking tricyclic antidepressants. Overdose is frequently fatal, so you can overdose on tricyclics. It's not very easy with other medications, with other antidepressants. Patients with bipolar disorder may be pushed into mania or rapid cycling, and that is a problem. Amitriptyline, also known as Elavil, is low in norepinephrine activity, low in serotonin activity. It has high anticholinergic effects. It blocks acetylcholine, and it's high in pain control. Now, if it blocks acetylcholine, the acetylcholine is where your memory comes from. Also has to do with movement. So people on amitriptyline may have short-term memory problems. Amitriptyline is used to manage major depressive disorders, anxiety disorders, migraine headaches, and neuropathic pain. Amoxapine ascendin is high in norepinephrine activity. It's low in serotonin activity. It has moderate anticholinergic effects, and it's low in pain control. Amoxapine works as an antidepressant rapidly. You hit a therapeutic dosage at about 1 to 2 weeks, and it has been used as an antipsychotic. Clomipramine, anafranil, is low in norepinephrine activity, high in serotonin activity. It has high anticholinergic effects, it blocks acetylcholine once again, and it's high in pain control. And of course, that leads to short-term memory problems. It's used to treat OCD, depressive disorder, panic attacks, and anxiety. Disipramine or norpramine is high in norepinephrine activity, low in serotonin activity. It has low anticholinergic effects. Once again, short-term memory problems, and low in pain control. Disipramine is used as an antidepressant and to treat ADHD, especially adult ADHD. Doxepin Sinequan is low in norepinephrine activity, low in serotonin activity. It has moderate anticholinergic effects, once again, memory problems, and it's low in pain control. Doxepin is used to treat major depressive disorder, anxiety disorders, chronic hives, and insomnia. Imipramine, also known as tofranil, is low in norepinephrine activity, low in serotonin activity. It has moderate anticholinergic effects, memory problems, and moderate in pain control. It's used to treat depression, anxiety, and panic disorders, and enuresis. Meprodoline, Ludamil is high in norepinephrine activity, low in serotonin activity. It has low anticholinergic effects and moderate in pain control. Metoprolol is used to treat depression, anxiety, panic disorder, and neuropathic pain. Nortriptyline, also known as Pamelor, is moderate in norepinephrine activity, low in serotonin activity. It has moderate anticholinergic effects and moderate in pain control. Nortriptyline is used to treat depression, anxiety, ADHD, neuropathic pain, and to help in smoking cessation. Nortriptyline. Protriptyline Vivactyl is high in norepinephrine activity, low in serotonin activity. It has moderate anticholinergic effects and low in pain control. Protriptyline is used to treat depression, ADHD, and its energizing effect is used to treat narcolepsy. Trimipramine, Sermontil, is low in norepinephrine activity, low in serotonin activity. It has high anticholinergic effects and high in pain control. Trimipramine is used to treat depression, anxiety disorder, psychosis, and insomnia. Okay, so that's the tricyclics. Now we're going to start talking about the monoamine oxidase inhibitors. Yeah, they were the first ones. Monoamine oxidase inhibitors were developed in the 1950s, earlier than tricyclics, and it worked, and people were real happy about it. But then they started seeing some really serious side effects. So the monoamine oxidase inhibitors were first developed in 1952. They were found to be antidepressants. They were looking for an anti-tuberculosis medication, but it worked as an antidepressant. So they put it on the market as an antidepressant. In 1962, they'd been using it for 10 years, and of course everybody was going, "Oh, this is the most wonderful drug in the whole wide world." But what they were seeing was that some people were having problems with it if they didn't control their diets, or if they ate some interesting food, then they had a problem. 1962, there was an investigation of a death from hypertensive crisis for someone ingesting tyramine-rich foods. Tyramine-rich foods, we'll talk about those in just a second. while taking an monoamine oxidase inhibitor. In the 1960s, an institution of strict dietary restriction of tyramine-containing foods and other interacting substances. Significant reduction in use due to introduction of tricyclic antidepressants, which do not have the severe restrictions of monoamine oxidase inhibitors. So one of the things we discovered in the 1960s was, yeah, it works. It's a great antidepressant, but you've got to really control your diet, or you can cause some real serious problems. 2006, they developed a transdermal Celogene patch known as MSAM to treat depression. They weren't giving it to anybody unless that individual was not responding to other means of controlling depression. The features of monoamine oxidase inhibitors, they are an effective antidepressant for those who can adhere to the necessary restrictions and tolerate many other side effects. Very long duration, requiring caution when mixing with restricted substances or medications. So if you're taking a monoamine oxidase inhibitor, usually the only reason you're taking an MAOI is because you're not responding to other medications like SSRIs, SNRIs, or tricyclics. They would give you any of those before they gave you monoamine oxidase inhibitors. But there are people that do not respond, and they are still depressed. And there are different ways to deal with this. And one of the ways is to give them monoamine oxidase inhibitors. Lots of medications you can't take. There are foods that you can't eat, and we're going to go over those right now. Tyramine-containing foods, and this is not a complete list, but this is just shows you how broad the tyramines are as far as foods are concerned. Certain tyramines may be consumed in moderation, but it's dangerous. Many cheeses have tyramines, chocolate, soybeans, hot dogs, dry sausage, any caffeine, so that's coffee and tea, and of course most soda pops, beer, wine, pickles, olives, anything that is preserved or pickled. You can't eat anything that's pickled. Olives, which are it's usually put in, pickles are put in saline solution. Drug-to-drug interactions with monoamine oxidase inhibitors, multiple prescribed and over-the-counter medications can be potentially lethal. So if you're taking MAOIs, it's really tough to find a medication you can take. Serotonin syndrome with SSRIs and many others, and this is another reason why people do not take monoamine oxidase inhibitors. The available formulations of monoamine oxidase is phenelzine or Nardil, isocarboxazide is Marplan, and tranylcypromine, also known as Parnate. Yeah, I know all those chemical things are hard to say. I just know it as Nardil, Marplan, and Parnate. Similar medications to Nardil, Marplan, and Parnate would be Eldepril or Selagiline. Selagiline is used to treat Parkinson's syndromes. It lessens Parkinson's syndromes, but it's a monoamine oxidase inhibitor, which means that you've got to stay away from most tyramines, and you can't be taking any other medication. Selective B inhibitor at low doses, so restrictions are not critical. At higher doses, acts like a typical MAOI, and so there is need for restrictions. Recently, it's been available as a transdermal patch, MSAM, that's for the people with Parkinson's disease, to treat the depression and not needing food restrictions at low doses, although there are still some drug interactions. Reversible selective A inhibitors, not available in the United States, but overseas. So people with Parkinson's disease can use MSAM. Okay, so we're not going to talk about monoamine oxidase inhibitors anymore. Very restrictive, not that many people on MAOIs, but you need to know if they are, because you can't give them other SSR. You can't give them SSRIs, you can't give them SNRIs, you can't really give them tricyclics. So yeah, this is dangerous. And a lot of times, you know, people think they're treating themselves, they're smarter than the doctor. So, you know, they come across some Nardil, Marplan, or Parnate, and they think, oh, this is really working. And then they, you know, not a good idea. Okay, let's talk about the mood stabilizers. Mood stabilizers are used to treat bipolar disorder. Many mood stabilizers are used to treat various seizure disorder types, migraines, chronic pain syndromes, aggression, impulsivity, augmentation of antidepressants and antipsychotics. Other classes of meds are also used in bipolar treatment, usually in combination with mood stabilizers. Mood stabilizers are used in the treatment of acute mania versus prophylaxis versus depression. And that's what happens. Bipolar disorder, and we haven't really, I'm not sure how much they talk about bipolar disorder. Bipolar disorder is really kind of interesting. The manic phase, right after the manic phase, you dip into the depressive phase, and it tends to be fairly severe. And a lot of the reason why it's so severe is because the mania is like, you know, snorting cocaine, but the depression is just that much worse. It's actually not as bad, but because you were up here, then down here seems really, really low. And there you go. Lithium, carbamazepine, and valproic acid are some of the mood stabilizers. They're older mood stabilizers. In 1949, lithium was recognized as an anti-manic, so it works on manic episodes. Lithium toxicity identified after being used as a substitute for sodium and salt. They thought maybe that they could, this is in 1949, they thought maybe they could keep people from being manic by putting, instead of making sodium chloride, making lithium chloride, and they just put it in salt and replaced the sodium. Well, it didn't work. Kind of not a bad idea. They were having problems with men coming back from World War II. They were having problems with some men adjusting back to civilian life. And so they thought that if they could do this, then it might be easier to get them to help them adjust to civilian life because it would control their manic episodes. But of course, it didn't work. As we know now, it didn't work. But, you know, it's an idea, I guess. 1966, French researchers demonstrate valproate's efficacy in treating mania. Before that, the only treatment we had was lithium. And, of course, the first time I came in contact with it was drawing lithium levels on individuals whose bipolar disorder was being controlled with lithium medication. 1978, and valproate, of course, is an anticonvulsant. So this was really important because lithium is a toxic heavy metal, just like sodium can be. You need a certain amount of sodium in your system, not so much the lithium. 1978, significant studies demonstrate lithium's efficacy in bipolar disorder. We already knew this, that it controlled mania. 1980, studies demonstrate effectiveness of carbamazepine as in bipolar disorder. And carbamazepine is also an anticonvulsant, anti-seizure medication. The features of lithium. Lithium is the only mood stabilizer without significant anticonvulsant properties. Up to 70% response rate, so it's fairly efficacious. 70% is pretty high. SSRIs, for example, they're hitting around 50% these days. In the beginning, they said they were 90%, 90, 95%. But then they realized, oh, wait a minute, not everybody's responding to them, and now we're looking at SSRIs more with a more jaundiced eye. But lithium really works. We've been using it for what 75 years, and it's. See, I was born in 1949, so we've been using it for 74 years. As long as I've been alive, we've been using lithium. Lithium was demonstrated effectiveness in reducing suicidality, less effective in rapid cycling and mixed bipolar disorders. Full clinical effect may take up to 1 to 2 months. So that's one of the reasons why we were drawing so much blood on those individuals. We're trying to determine how much lithium they had in their system, because it can take up to a month. Actually, SSRIs can take up to 6 weeks to get up to therapeutic levels. Serum levels guide dosing. It's excreted through your kidneys, and it all depends on how well your kidneys work as to how well it is burped out of your system. Minimal liver mediated drug-to-drug interactions. So there you go. The side effects of lithium: fine tremors, weight gain, and nausea, which is what most people complain about, is the weight gain. Increased thirst and urination. More severe toxicities include coarse tremors, gait instability, vomiting, diarrhea, and confusion. Increased risk of toxicity with fluid or salt restrictions. And this is one of the reasons why we had to monitor the amount in somebody's blood. We needed to control. We didn't want to overdose the individual. You can kick them into toxicity. It does accumulate in your body, so it's really important to maintain, to understand how much you've got in your system and how much your body is retaining. Increased risk of toxicity with fluid or salt restriction, hot weather sweating, use of anti-inflammatory drugs, ACE inhibitors and angiotensin receptor blockers, and diuretics. Anything, see, this stuff is cleared out of your system through your kidneys, and anytime your kidneys are overworked or underworked, or you're losing fluid out of your body due to hot weather and sweating, you need to reduce the level of lithium. This is really kind of interesting. So anti-inflammatory drugs will make you retain water. ACE inhibitors, angiotensin receptor blockers, and diuretics will make you retain water, and because of that, it dilutes out the lithium. And so, yeah, this is kind of an interesting problem. It may cause kidney and thyroid dysfunction, so there is a need for regular monitoring of creatinine, BUN, and TSH. These are creatinine, BUN are kidney functions, and TSH, of course, is a thyroid function. And that's another reason why we're drawing blood on people who are taking lithium. Females are at much greater risk of lithium-related thyroid dysfunction. Okay, so now we're going to talk about the anticonvulsants. That's lithium. Lithium is a heavy metal. Now we're going to talk about the anticonvulsants or anti-seizure medication. So people will take carbamazepine for epilepsy. The other name for carbamazepine is Tegretol. It's used in acute mania and bipolar maintenance. It's more effective than lithium in rapid cycling and mixed states. It's less effective in bipolar-related depression because it doesn't do anything with depression. It's an anticonvulsant. Serum levels can be helpful. Remember, the lithium affects your norepinephrine level, and norepinephrine is one of the things that makes you happy or sad. Not enough makes you sad. Too much, not too much. Increased amount will make you happy. So because lithium works on norepinephrine, it can be used as an antidepressant. Carbamazepine doesn't have anything to do with norepinephrine or dopamine or serotonin. So it doesn't do anything with depression. All it does is control the the rapid cycling. It controls the bipolar disorder. You need to monitor the Tegretol, and of course, this is when I first came in contact with carbamazepine. Multiple significant drug-to-drug interactions affecting both other medications, reducing their levels, and other medications affecting it, increasing your carbamazepine level. So you've got to be really careful about what other medications that you're taking. It induces its own metabolism, so it may need to adjust dose over several weeks. And this is another reason to draw blood on these individuals. Side effects of Tegretol: gastrointestinal problems, nausea, constipation, diarrhea, appetite loss. Central nervous system, it's sedating, and that's one of the reasons why people don't like it, because it makes them feel dull. Dizziness, unsteadiness, and confusion. Benign rashes are common. Catastrophic rashes are rare, but it can cause a rash. Kind of feels like eczema. Many possible serious abnormalities in your CBC and your complete blood count. So we're looking at your red cells. We're also looking at your white cells. It may reduce your sodium levels, causing hyponatremia. Liver function abnormalities are rare, but it is possible. Toxic metabolite, 10 to 11 carbamazepine epoxide, can create problems via drug-to-drug interactions with valproate, lamotrigine, and phenobarbital. It's independent of carbamazepine levels. It can be checked separately. Okay, so when you're taking Tegretol, you have to be careful of the medications that you're taking. This is a second anticonvulsant, anti-seizure medication, valproic acid, also known as Depakote or valproate. It can be dosed rapidly to treat acute mania, and that's the beauty of valproic acid. It is more effective than lithium in rapid cycling in mixed states. It is used by some to treat aggression and impulsivity and other psychiatric disorders. So this one is, whereas carbamazepine is just controls the bipolar disorder, this can control other aspects of bipolar disorder. It's used to treat aggression and impulsivity in these individuals. It is approved for migraine prophylaxis, and so it takes care of that aspect. Serum levels can be helpful in guiding the doses. Again, commonly used at top or above levels stated for seizure control. Some suggest supplementation with carnitine, selenium, and others to reduce side effects of the Depakote. The side effects are kind of interesting. It causes nausea, weight gain, and unsteadiness, also known as ataxia, hair loss, interestingly enough, and causes fine tremors. Liver dysfunctions: it decreases your platelets, causes thrombocytopenia, which means that if you get cut, then you will possibly bleed because you don't clot as well as you should. Pancreatitis, it's rare, but it's potentially serious. Pancreatitis is always serious. Not that you're always going to die, but it always needs to be treated. Can't live without your pancreas. Polycystic ovary disease suggested by some reports. Ammonia level can be increased, particularly in those rare individuals with genetic metabolic deficits. Why do your ammonia levels increase? There's two major reasons why your sweat would smell like ammonia. One has to do with the fact that you've got a kidney problem. The other has to do with the fact that you are dehydrated. Okay, so you need to determine if your sweat smells like ammonia, and it does this when it hasn't been that hot and you haven't been working out a lot, then you need to do something about it. You need to go see a doctor, make sure your kidneys are okay. It's probably dehydration, but there is always a possibility that you have kidney problems. Drug-to-drug interactions by various mechanisms of numerous other anticonvulsants, aspirins, and others. And this is one of the reasons why people have to stay away from aspirin when they're taking valproic acid, also known as Depakote, because it can aspirin dilutes your blood. That's not right. It thins your blood. That's the term that they're using, and it can cause bleeding. And so this is really something that you have to keep an eye on. Lamotrigine, oxycarbazepine, topramate. Well, anyway, let's not go into that. These are some of the new mood stabilizers. Lamotrigine was developed in the 1990s. It was investigated for mood stabilizing properties after patients on it for seizure disorders reported benefits. Most newer approved anticonvulsants are investigated for mood stabilizing properties. It has been, lamotrigine has been approved for bipolar 1 maintenance. And that is the newer mood stabilizers. Lamictal is minimally sedating, unlike other mood stabilizers. It appears to be especially effective in treated bipolar depression, but unproven to treat mania. Early use as an anticonvulsant in children raised concerns about potentially life-threatening rash, and this is known as Stevens-Johnson syndrome. It's a toxic epidermal necrolysis. Causes a life-threatening rash, as odd as that seems. I've seen this when I was working at Children's Hospital in Omaha. Initiating lamotrigine is done very slowly to decrease rash risk. Valproate greatly increases lamotrigine levels. Carbamazepine greatly decreases lamotrigine levels. One of the things you need to know about the anticonvulsants, the medications for epilepsy, there tends to be side effects for all of these, whether it's Depakote or Tegretol or Lamictal or whatever you're using. And this is one of the reasons why when they're trying to control a child's epilepsy, they go very slowly as far as the medications are concerned. And of course, the anticonvulsants are what we are using now more readily than the lithium, because lithium can be toxic if you're not careful. So we're using the anticonvulsants for bipolar disorder. Now, as we know, one of the problems with the anticonvulsants is that they make you feel confused. They make you feel dull. And for this reason, there's a lot of people that don't want to take them. And this is one of the reasons they stop taking their medication. They start feeling better and they go off of it because it makes them feel dull, and now they feel better, so they think they're fixed, and so they stay off their medication, and now we got a problem because they, of course, go back into crisis. Anyway, that seems to be what's happening. Trileptal, oxcarbazepine is used primarily in combination with other mood stabilizers, although efficacy is not clearly substantiated. Modified carbamazepine with potentially less side effects in drug-to-drug interactions with carbamazepine. What we've been trying to do is we've been trying to find newer mood stabilizers that work as well as the old anticonvulsants, but they have less side effects. The side effects are what drive people away from them. And of course, people don't want to feel dull. They don't want to feel confused. This is not a good feeling for anybody. So they will go off their medication, or they'll only take a half dose, or they'll do some really interesting things. And this is one of the reasons why we're looking for something else. We're looking for something with less serious side effects, because people go off of them, and now we got a problem again, because whatever the problem was before, it's potentially worse now, because it's what they refer to as a rebound effect. It's worse than it was when you first started taking your medication. 10 to 11 carbamazepine epoxide is not a metabolite, so higher doses requires it if switching from carbamazepine. Topamax is research questions as to its use as a mood stabilizer, although there are scattered reports out there that suggest possible benefits. The interesting thing about Topamax, people taking it have weight loss. There is still cognitive dulling. It causes problems in your kidneys. Kidney stones are a problem. And that usually has to do with ingesting too much milk, too much, there's lots of different types of kidney stones. That all has to do with heavy metals accumulating. And I know it sounds like I'm saying you got little bullets in your kidneys, but that's not what it is. It's a crystallization of all this stuff. And metabolic acidosis is another problem. Keppra, efficacy in bipolar disorder, unsubstantiated, although scattered reports suggest possible benefits. Minimal drug-to-drug interactions. Zonegran, efficacy in bipolar disorder, unsubstantiated, although scattered reports suggest possible benefits. Side effects similar to topramate, including weight loss. Symbyax is approved to treat bipolar depression. It is olanzapine and fluoxetine combination. It's known as Symbyax. Those are both antidepressants. Okay, so let's talk about the antipsychotics. The first one they discovered was chlorpromazine. It was synthesized as a sedating antihistamine. It worked as an antipsychotic. 1952, it was they started using it as an antipsychotic and for mania. 1953, the first reports of chlorpromazine-associated movement disorders. That's the tardive dyskinesia that they talk so much about. 1958, haloperidol was developed. 1962, long-acting injectable fluphenazine was developed. 1970, dopamine hypothesis of schizophrenia was suggested. This was really important because once we discovered that too much dopamine could potentially be the problem, we could block dopamine receptor sites, and that worked for some people. 2005, Katie trials shows positive outcome for perfenazine and compared to newer antipsychotics. So there you go. Neuroleptics neuroleptic means seize the neuron, referring to the tendency to cause stiffness and other neurologic symptoms. Early methods of dosing would achieve neurolepsis and then back the dose down. So what they tried to do was treat these people until they became neuroleptic. And once they became neuroleptic, they started backing down their dosage. So they needed to make sure that there was going to be an effect, and then they backed it down until they were more functional. So they locked them up. That's what neurolepsis means. They made them stiff, and as soon as they did that, then they would back the dosages up. Major tranquilizers refers to the tendency to sedate, quiet, and create a blandness in patients, similar to the negative symptoms of schizophrenia. Differentiates from the benzodiazepines such as Valium, which were referred to as minor tranquilizers. These are the major tranquilizers. Typical traditional conventional antipsychotics differentiates these drugs from newer atypical antipsychotics. Dopamine receptor antagonists highlight strong dopamine activity and tight binding to D2 receptor sites. Extrapyramidal symptoms. Pyramidal system is responsible for voluntary movement. Extrapyramidal system is responsible for involuntary muscle action. It includes dystonias, Parkinsonism, akathisia, and tardive dyskinesia. Acute dystonia is sustained muscular contraction of the neck and eyes and throat. It generally occurs soon after starting your medication, and it's known as acute dystonia. Now we can back you off of these antipsychotics, and the acute dystonia will go away. That's one of the things that you're looking for. Akathisia is uncontrollable continuous motor restlessness. It can occur anytime in treatment, but generally it occurs in the first few weeks, and that's one of the other things they were looking for in the beginning. It's easily misdiagnosed as underlying psychiatric disorder, akathisia. It's restlessness, agitation. Parkinsonism is tremor, muscle stiffness, slowed movement, drooling. Generally occurs beyond 1 week after starting your medication. And now is the serious one, tardive dyskinesia, spastic facial distortions and tongue movements. It may extend to the neck, trunk, and extremities. It sometimes has a delayed effect, usually beyond 6 months from starting your medication. Risk increases with the duration of exposure to antipsychotics. It's known to occur without antipsychotic therapy, tardive dyskinesia. It may be permanent, occur on discontinuation, or dissolve on its own. Normally it is permanent. It's worsened by medications used to treat other extrapyramidal symptoms. So sometimes they cause more of a problem by treating the symptoms. You know, that's medicine for you. Neuroleptic malignant syndrome, pipe-like rigidity, fever, tremors, altered level of consciousness, hypotension, tachycardia, laboratory abnormalities, usually elevated white blood cells because your body thinks that you have an infection, and also your CK levels. That's creatinine phosphokinase. We used to call it CPK. They've shortened it to CK. That has to do with using your muscles, damaging your muscles actually, and that comes from all the movement that you're doing. So the CK level is increased. We used to diagnose heart attacks with CK because it's a smooth muscle, and we got a certain type of CPK increase with a heart attack. Mortality is between 10 and 20%. It can occur anytime in the course of treatment, and that's one of the real tragedies of trying to treat schizophrenia. Anticholinergic effects, dry mouth, blurred vision, constipation, urinary retention, and mydriasis, which is dilated pupils, continually dilated pupils. Clinical effect and potency, low potency, chlorpromazine, mesoridazine, thioridazine, they're medium, high sedation, low, medium extrapyramidal symptoms, high anticholinergic effects. If we have somebody who's schizophrenic and they're psychotic, we're trying to treat them, we're going to go with the lowest doses and the least extrapyramidal symptoms possible. Medium potency, profenazine, loxapine, and molindone. Low medium sedation, high extrapyramidal symptoms, low medium anticholinergic effects. Usually, okay, so who are we dealing with here? If somebody has developed schizophrenia as a adolescent or as a child, they're going to have more severe symptoms of schizophrenia than somebody who develops schizophrenia as an adult or as an older person. We see this with individuals that are developing Alzheimer's disease. They will have psychotic episodes. These individuals are usually easier to treat. The older you are when you develop your symptoms, the less severe your symptoms are. So the older the person, the easier it is to treat them. The younger the person, the harder it is to treat them. They'll probably have a lot of extrapyramidal symptoms. This is a really serious problem. High potency, flufenazine, trifluoperazine, thiothiazine, haloperidol, and pimozide. Medium low sedation, high extrapyramidal symptoms, low anticholinergic effects. You might wonder, why in the world would we ever treat somebody that they have such horrible side effects? And the answer is that's the only way that you can help them, to make them as normal as you possibly can, despite their psychosis. Chlorpromazine or thorazine is a cardiac risk. It causes weight gain. Fluphenazine or prolixine has a long-acting injection is available. Haloperidol, also known as Haldol, has long-acting injection available. Lipoxyphene, mesoridazine has cardiac risks. Melindone is another antipsychotic. These are all the older antipsychotics. We try not to use these unless we have to. Melindone, also known as Moban, perfenazine, pimozide has a cardiac risk. Thyroidazine, high cardiac risk. Thiazine, Navane, trifluoperazine. You probably won't see hardly any of these. Even if you work in a psychiatric ward, we try to give them. We don't try to use the older antipsychotics. If they have a psychotic episode, you might see them hit with thorazine, or haloperidol. Other than that, the probability of seeing any of this stuff is fairly remote. The newer antipsychotics, thank goodness. 1990, clozapine was introduced in the United States after a long delay related to safety concerns from overseas. 1994, risperidone. This is what you will probably see more than any other antipsychotic. Risperidone. 1996, olanzapine. 1997, this is when they were developed. We were looking for better antipsychotics. Olanzapine, quetiapine in 1997. In 2000, ziprasidone. 2003, aripiprazole. 2004, ADA-APA. The consensus report on obesity and diabetes and those taking antipsychotics. This is really kind of a serious side effect. Atypical antipsychotics are second-generation antipsychotics, serotonin dopamine antagonists. The mechanism, it adds serotonin activity, which of course is an antidepressant. It binds more closely to dopamine receptors. Clozapine, initially rejected as an antipsychotic because of its seemingly reduced dopamine impact and lack of EPS. Now, this is really kind of an interesting situation. There are some schizophrenias that where dopamine is not involved, but most schizophrenias will react to dopamine blockage. If you can block the dopamine receptor sites, then the individual will seem better. Indication and uses: schizophrenia and other psychotic disorders, acute bipolar mania, and maintenance. Augmentation of antidepressants and mood stabilizers, and aggression and impulsivity. This is what we're trying to control. The features: less risks with extrapyramidal systems and movement disorders with the newer antipsychotics. Greater effect on negative symptoms of schizophrenia. The cautions: greater risk of obesity, diabetes, and lipid abnormalities. And this is usually what kills the individual is the lipid abnormalities or the diabetes. Clozapine affects olanzapine, affects quetiapine, risperidone affects ziprasidone and aripiprazole. It requires regular monitoring of metabolic parameters, potential stroke, mortality risk in the elderly, extrapyramidal system, movement disorders, and NMS are all still occur, although much less than with the typical antipsychotics. So this is what we will go with, the newer ones. Apiprazole is also known as Abilify. You probably know it as Abilify if you ever watch television drug commercials. It's a unique, complex mechanism. It can be either activating or sedating. It can nausea is common with this one, and for that reason, a lot of people don't like it. Clozapine is the most effective antipsychotic we have now. There's a risk of agranulocytosis. Agranulocytosis, we're talking about your neutrophils. Your neutrophils are the white blood cells in your system that fight bacterial infections. And you get agranulocytosis with Clozaril, which means that you can't fight off bacterial infections as well because you have a decreased number of these types of white blood cells. Really serious stuff. CBC weekly for 6 months, biweekly for 6 months, and this is mainly because they're trying to find out what is going on with your neutrophils. Multiple other side effects of drug interactions. You have to reduce smoking. One of the things, if you've ever been around some people that are schizophrenic, one of the things is that they smoke a lot. They smoke cigarettes. They chain smoke, and then one of the reasons they smoke cigarettes is because it increases your dopamine level, and that, of course, makes them feel more normal. One of the problems with people with schizophrenia, with some people with schizophrenia, not everyone, because some people are not reactive to dopamine inhibitors, is that they have an increase of, if you can increase the dopamine level, and that's what most of the drugs that we give them to reduce their schizophrenic symptoms, if we can increase the amount of dopamine in their system, then that will reduce their symptoms. And that's what tobacco does. Tobacco increases your dopamine level. That's why people like it so much, is because they're getting this dopamine spike every time they take a puff. So you'll see these people chain smoking. But with clozapine, that doesn't work. Olanzapine, Zyprexa, Zydus, significant weight gain, diabetes, and lipid abnormality risks. Levels are reduced by smoking, and that's the reason why. Quetiapine, Seroquel, is approved dose range considered low by many. It has low extrapyramidal symptoms. It's used commonly as a sedating agent. Risperidol, this is the one I've seen the most of. Of course, I haven't been out there for a while, not since the early 2000s. Most like typical antipsychotic at higher doses. It's available in long-acting injection called Consta. Ziprasidone, Geodon is approved for dose range considered low by many. Initial cardiac concerns appear significant for most. Must be taken with fat-containing meal. There you go. Cogentin, benztropine is the least sedating. It's the most commonly used now. It's an anticholinergic. Biperidone. What are we talking? Oh, we're talking about anticholinergics. I'm sorry. All right, we're done with antipsychotics. Now we're talking about anticholinergics. Cogentin is the most widely used. Benadryl, Artane, Simitrel. They're not anticholinergic. It's used rarely to treat extrapyramidal symptoms. To treat extrapyramidal symptoms, tremors, stiffness, drooling, dystonias, akathisia may not respond to anticholinergics. Tardive dyskinesia may worsen with anticholinergics. Dry mouth, constipation, blurred vision with anticholinergics. Extrapyramidal symptoms are thought to be cholinergic dopamine imbalances. Okay, now we're going to talk about the benzodiazepines. Librium was the first benzodiazepine. I didn't realize that. Librium was the first benzodiazepine that was developed. diazepoxide, 1957, Librium was developed. We used this a lot. We gave this out a lot during the 1960s and 70s, during Vietnam. Librium and Valium. Gave them out like candy. 1970s, Valium, diazepam, a top-selling drug in the United States until Prozac. 1986, Xanax, alprazolam was developed, and it became the top-selling drug in 1986. And then in the 1990s, SSRIs replaced benzodiazepine. The benzodiazepines for antipsychotics. I'm sorry, as anxiolytics for anxiety. We stopped treating anxiety with as much anxiolytics as we did before because there were side effects. The general characteristics, they differ in action and duration, drug-to-drug interactions, and side effects based on differences in absorption rate, lipid solubility, and metabolism. Indications uses include anxiety disorder, panic disorder, mania, seizure disorder, phobias, insomnia, alcohol withdrawals, muscle spasms, agitation, catatonia, and akathisia. Hospital use, you can use it as an IV or intramuscular. In sedation for procedures, they'll give them shots of Valium usually. When I had my knee surgery, they gave me a shot of Valium before they took me in to do the surgery. Side effects, sedation, cognitive impairment, anterograde amnesia, and I didn't have either any of that stuff. Respiratory depression at high dose or with alcohol. So don't take them with alcohol, you'll stop breathing. It may worsen obstructive sleep apnea symptoms in susceptible individuals. Risk of abuse is small in individuals who are not abusing other substances. Withdrawal symptoms and physical dependence are not in themselves problematic if reductions are done gradually to minimize symptoms. Use of longer-acting agents to minimize between-dose breakthroughs and avoiding taken-as-needed dosing are helpful. Symptoms of withdrawal may represent breakthrough of the underlying anxiety disorder. This is the rebound effect that I was talking about before. Needing to increase the dose tolerance, not generally an issue at therapeutic doses. Okay, these are the benzodiazepine, the short to mid benzodiazepines, Xanax. Librium is a long-acting benzodiazepine. Mid to long, Klonopin, long-acting, Transine, Valium, Dalmane. Prosam is a mid, Prosam and Restoril are mid-acting benzodiazepines, and the short to mid are Ativan and Cirax, with Halcyon is a very short one. Okay. Other anxiolytic hypnotics, chloral hydrate was first used in 1869. That was a long time ago. Ambien was developed in 1992. Ambien. The generic was approved in 2006. Hypnotics are medications to induce sleep. Non-benzodiazepine anxiolytics. Benzodiazepines have too many side effects, so you wouldn't want to use them as a sleep aid. But these are the things that you can use. Ambien, your hypnotics. The problem is if you use them, then you can't continue to use them because you will become addicted to it. You won't be able to go to sleep without it. That's the problem. Newer anticonvulsants are used off-label as both anxiolytics and hypnotics, although efficacy is unproven. Trazodone and some tricyclic antidepressants are used as hypnotics to help people go to sleep. Newer hypnotics are active at GABA1 receptors, except for Ramelteon. Other anxiolytics and hypnotics, Buspar, which is buspirone, is a subtle anxiolytic and slow. It gives you a slow response. Chloral hydrate, Noctec, it will put you to sleep. This is what they used to use as to Shanghai people. Mickey Finn. This is how they knocked you out with chloral hydrate. It's a hypnotic, a rapid tolerance, toxicity in overdose. Chloral hydrate is what? 2 molecules of alcohol stuck together. Antihistamines, Vistarol, Benadryl can be used as hypnotics. They'll put you to sleep. Anticonvulsants, which are mildly sedating and calming, Neurontin, Lyrica, and Gabatril. Wait a minute, I've gone the wrong direction. Okay. Selective benzodiazepine receptor activity, GABA, hypnotics, Lunesta, Sonata, Ambien can be used as a hypnotic. Melatonin receptor agonist, Razaram. Stimulants, the ADHD drugs. Ritalin was approved in 1956. 10% of 10-year-old boys in the United States are on stimulants of some kind. 1 out of every 10. So if you have 20 boys in your class, 2 of them are on ADHD medication, probably more. 2.5 million children in the United States are on stimulants. Recent FDA warning about increased cardiovascular risk, sudden death for patients on stimulants. Something to think about. Inomoxetine Strattera is a non-stimulant treatment for ADHD. It's a recent caution about suicidal ideations in these individuals that are taking Strattera. Rare liver function impairment. Catapres, clonidine is another ADHD drug. Antihypertensive alpha-2 agonist. It's used for ADHD, substance withdrawal Tourette's syndrome, and other problems. Pimeline, also known as Silert, is rarely used stimulant due to liver toxicity. So these are things that hit the market. Everybody was going, oh, this is great stuff. Then they took it off the market because they found there were too many side effects. Dexedrine, dextroamphetamine, has multiple long-acting forms. It causes insomnia, headache, tremors, exacerbation of tics, nausea, weight loss, blurred vision, and overstimulation. Ritalin, methylphenidate, is a very common medication that's used. It has the same reactions as dextroamphetamine. Modafinil, Provigil, is a non-stimulant. It's poorly understood mechanism of action, but it works. It's used for sleepiness related to narcolepsy, obstructive sleep apnea, depression, and multiple sclerosis. It's used for ADHD is being investigated. Medications for dementia, 1993. I can remember when Cognex hit the market in 1993. Tacrine. 1996, Aricept was developed. Donepezil. 1997, generalizability of approval studies questioned. So they were thinking, wait a minute, maybe we approved these too early. Namenda was approved in 2003 for people with severe to moderate to severe Alzheimer's dementia. 2004 detailed British study questions efficacy of cholinesterase inhibitors. Now we have a new one on the market, and they say it actually reduces Alzheimer's disease. It's not in this lecture, and I guess I need to get that for you. General characteristics of the search for a treatment of Alzheimer's dementia is driven by intense human suffering and immense demographic numbers. Why do we have so many people with dementia? Because we have so many people that are making it into old age now. People used to die in their 50s and 60s. Now they're living into their 70s and 80s, and Alzheimer's is being developed, is developing in them, where they would have died 10 or 20 years before, and they would never have developed Alzheimer's disease. The studies that support use of these medications generally find subtle benefit or slowing of decline, and that's what they're actually looking for. There is significant debate about the benefit versus cost, the money and side effects of using these medications. Treatment for behavioral issues and dementia has been complicated by FDA warnings about the risk of using antipsychotics in the elderly, and this is a problem because when they develop Alzheimer's disease, a lot of times they will have psychotic episodes. Cholinesterase inhibitors address one theorized mechanism for this complex disease: Aricept, Rimonil, Exelon, Cognex. We're not using Cognex anymore. It was the first one, but we're not using it anymore because it has liver toxicity. Namenda, complex activity versus NMDA, glutamate-mediated receptors. It may have more broad psychiatric applications. We're not exactly sure at this point. The meds to treat substance abuse, use of medications and substance abuse. To treat withdrawal symptoms, benzodiazepines, anticonvulsants, and clonidine. To treat comorbid psychiatric disorders, anxiety and depression are common. You can use SSRIs, mood stabilizers, and benzodiazepines. To prevent relapse, you need to use deterrence and craving control. That would be, my brain's not working. Disulfiram is used as an antabuse is the other name for it. It's used as a deterrent. It requires motivated patience. It works on alcohol, makes you vomit if you drink alcohol. Camprol is a craving control, minimal drug-to-drug interactions, efficacy shown in some studies. Acamprosate. Naltrexone, there you go. That's what I was trying to think of just a minute ago. It's an opioid antagonist. It's a high response for placebo-caused, some to question study design. Potential liver toxicity, Vivitrol injectable naltrexone lasts for 30 days. So you can give a guy a shot of this stuff and it will make them not crave opioids. Or actually anything. It actually works on all the cravings. Naloxone is another treatment for opioid dependence. It contains both an antagonist and an agonist. Zyban is identical to Wellbutrin. It treats nicotine craving. Others, several anticonvulsants, topramate, etc., have been used for craving reductions. And that's not it. The uses of these drugs, psychiatric uses of antihypertensives. The uses of these drugs are off-label and carry additional potential side effects from their cardiovascular actions. Potential psychiatric benefits have often been discovered while these agents were used for their primary indication. And of course, you have to monitor their blood pressure because it lowers your blood pressure. And potentially, if you take them off-label, then you may be lowering your blood pressure too much. Alpha-2 adrenergic agonists, clonidine, quanfacine, prazosin is used in ADHD and Tourette's syndrome and PTSD. Prazosin is found helpful in reducing PTSD-related nightmares. Beta blockers, propranolol, Inderol is used for akathisia, lithium-induced tremors, performance anxiety, and aggressive behavior. Pindolol has been considered for antidepressant augmentation. Multiple drug-to-drug interactions. It's avoided, and you have to avoid it if you're asthmatic or diabetic and on insulin. And if you have certain cardiovascular diseases, you have to stay away from the beta blockers. Calcium channel blockers, diltiazem, verapamil, and nimodipine. It may be helpful as additional agents in bipolar maintenance, multiple drug-to-drug interactions, and precautions. And there you go. Okay, so there's the antipsychotics. This was about psychotropics. So psychotropic medications are things that work on your brain, or that change the working of your brain. Anything that works that way is a psychotropic. And there you go. That's the end, and I am done with this class for this semester. I hope you enjoyed it as much as I did. Get all your stuff in. Don't forget your library paper. And I'll see you down the road somewhere.